This is second lecture, small intestine, part 2. Are you able to see the slides? Hope you are able to see the slides. My screen is visible to you. So part 2 consists of absorption, mainly the absorption plus some clinical condition. Okay. Here in this lecture, what we will do, we will just revise what we have covered in the previous lecture, the different parts or the functions. Then we will focus
Doctor,
mainly on
the screen is clear.
clear now.
Yeah, we
Seen
can see it. Yeah.
objectives. Okay. Okay. My voice is clear also.
Yes.
Okay. Thank you. So in this lecture, we will be discussing in detail about the absorption of water, electrolyte, and the important nutrient, fat, protein, vitamin B12, iron, how it is absorbed by the mucous membrane, and what is the role of different specialized mechanism. Now I will take you again back to the foundation PHSL lectures because it will require your attention, your knowledge of how the primary, secondary, tertiary, active transport, passive transport, facilitated diffusion, or symport, antiport, everything will come here. Then how the iron and calcium is absorbed in the small intestine, and what are the disturbances of the absorptive functions if there is any disease or pathophysiology occurring in the small intestine. How we can answer the questions about the disease based on our knowledge of physiology. So in the small intestine, as we have seen in the previous lecture, I will go slightly faster, that carbohydrate, protein, and fat and electrolyte, vitamins, and all the water is absorbed indiscriminately. They are absorbed indiscriminately without any quantity. But the calcium and iron is adjusted according to the body's need. If your body is having deficiency of calcium, then calcium absorption will become more. If you have iron deficiency, your iron absorption will become more. If you have full iron or excessive iron, iron absorption will be less. Whereas another important thing is that the absorption is mainly occurring in the earlier part like duodenum and jejunum. So very little amount is remaining for absorption in the terminal part or the last part of the ileum, except for vitamin B12 and bile salts. Okay. So we can say that there is a big reserve for the small intestine for the absorption. So at 50% of the small intestine can be cut, surgery can be done, removed without any change in the function of the small intestine in terms of absorption. But if the part which is removed is the terminal part, then there will be deficiency of vitamin B12 and bile salts because it is absorbed in the last 1/3, or you can say the terminal part of the small intestine. So for knowing how the absorption will occur, you have to know the histology or the structure of the small intestine. So for absorption to occur, you have to have, what is the basic requirement? The area should be more. If you have more surface area, the absorption will be easy and it will be larger. If you have very little small area, then absorption will be less. So a small intestine has got a large surface area. How you can explain large surface area? Because if you cut the small intestine and open, you will see first thing what you will observe in the dissection room, that there are circular folds. The area is not smooth. There are folds are present in the mucous membrane. Okay. So if you stretch all these folds, the size will become very big. This is how the surface area is increasing. If you stretch all these folds, unfold them, then the size will become double almost. Okay. Then if you go to the mucosa, you will see that it will be folded like this. Even on this smooth area, it is folded. These are called as the villi. These are called as villi. If I draw it in the circular here, you will find the lumen like this. Here is the lumen, and here is the all the layers. So these are the villi here. These villi again making the surface area bigger. Then if you see this small area where on the villi, suppose this is the villi, and there are epithelial cells. And if you see on the epithelial cell, if you just enlarge this epithelial cell, you will see, as I drawn in the previous lecture, various folds are found on one single epithelial cell. These are called as microvilli. Microvilli. So first is circular folds, then the villi, and then the microvilli. If you stretch them all, then the area will become almost many times, 100 times you can say, many times than the normal surface area. Okay. This is the larger surface area present in the small intestine. And for each villi, suppose this is a villus, in the each villus you will find there will be blood vessels, artery and vein, or capillaries and venules. And you will find in the center, let's say this is one villus, you will find artery, you will find a vein, and you will find a lymphatic. Lymphatics is also present. Okay, lymphatic vessel. So in each villus there will be arterial supply plus the capillary, and it becomes venule, and then it will be pouring into the venous side. So this is how absorption is taking place, and the method of absorption can be active or can be passive. What is mean by active or passive?
Need energy?
Yes. Which one need energy? Passive?
No, the active.
Active. How energy will come?
ATP.
ATP is very good. So you remember PHSL lecture up till now.
Yeah.
So each villus has a epithelial cells. If you remember, this is a villus, suppose, and each epithelial on the villus, you will find there are epithelial cells which have projection or brush border, and they are connected to each other with tight junctions. With tight junctions. Let's say I will draw now in a lumen, and let's say these are the epithelial cells. So in the epithelial cells, they are connected on the lateral side with tight junctions on the lateral border, which limit the passage of luminal content between the cells. So only passage will occur from within the cell, from the epithelial cell, from the lumen to the epithelial cell, and from epithelial cell into the interstitium, and from the interstitium into the blood vessel. Okay, this is how these are the steps from lumen to epithelial cell, from epithelial cell to the interstitial space, from interstitial space to the blood vessel or capillary, you can say. These are the stages of passage of food content, or the absorption is taking place in three places: from lumen to the epithelial cell, from the epithelial cell to the interstitial space, from interstitial space to the capillary. In any of these places, three places, if ATP is used, we call it as active process or active absorption. If there is no ATP used from here to here, then we call it as a passive absorption. For any absorption to occur, there should be a carrier. There should be a protein channel or a thing which will allow them to enter, which we call it as a carrier. So carrier are needed. And between this area, there is a lamina propria, which is a connective tissue. So how it occurs? Just I will skip this because there is a picture which I will show you now. Okay, before that, in the villus, as I told you, these are the villus. And on the villus, there are epithelial cells. So this area, the one which is going down here, the one this here, this is known as crypt, and a special name is given as crypt of Lieberkühn, crypts of Lieberkühn. Crypts of Lieberkühn secretes water and electrolyte along with the mucus. So the mucus and the succus entericus coming from this area, that is the crypts of Lieberkühn. Also, crypts of Lieberkühn are the places where the new epithelial cells are forming. So new epithelial cells are forming here, and they will move up. They will move up and reaching to here. And after that, after 3 days, these surfaces is removed. This whole surface, all these epithelial cells will be shed and come out in the stool. It is said that every third day, after every 3 days, the surface becomes new, completely new, not the old one or not the one which is last week. Okay, so this is how the circulation of epithelium cells is changing. So epithelial cells are removed every 3 days, and it is replaced by the new epithelial cells. And these are formed in the crypts of the Lieberkühn. So this was I was telling you that the small intestine is having circular fold. You can see here. I will change the color so that you can easily see. So these are the circular folds, again increasing the surface area. On the mucosa, you will see that there are villi. This is the projection, finger-like projection. On the villus, you will see epithelial cells, and on the epithelial cells, this is one villus. Each villus has got a capillary network, and in the center, you will find the lacteal. We call it as lacteal or lymphatic vessel.
Doctor, what
Okay.
is the use of crypt of leprechaun?
Crypts of Lieberkühn is the site where water is secreted, mucus is secreted, and also new epithelial cells are formed.
All right. Okay.
So this is making succus entericus. The intestinal juice will be secreted here in the crypts of the Lieberkühn. Okay.
All right. Yeah.
Now, yes, on the brush border, you will see on each epithelial cells, the projections are finger-like projections are there here. These are the sites where you will find the enzymes. Digestive enzymes are present for protein and carbohydrate. Okay. Now coming to the absorption. Absorption of sodium is absorbed by both passive without energy and active with ATPs through the transporters. Okay. So sodium will enter into the epithelial cells across the luminal border passively through the sodium channel. There are specific sodium channel which will be just allowing the sodium to enter. This is called as passive absorption. Or it can be travel inside by secondary active transport. Now, who will tell me the definition of secondary active transport?
It is
Sup-
like glucose and Na.
Suppose this is a lumen. On the lumen, this is the cell. Now here you have sodium. Okay. Now the sodium is absorbed by secondary active transport. Means the energy is
There is
not. Yeah.
there,
Is it energy utilization is there or not?
there is an energy from other transporter,
Like
Na glucose or Na potassium. I
no.
forgot.
If you remember on the basolateral membrane, basal side or lateral side, there is a pump. We call it as
Sodium
sodium.
potassium pump.
Yes, sodium potassium pump. So sodium potassium pump is always active, and this is utilizing ATP. This is causing loss of sodium from the inside to the outside. So because of decreased sodium and because increased sodium in the lumen, it will easily get from higher to lower concentration. But the energy is not utilized here on the border. That's why it is called as secondary active transport. Okay. Also, sodium can also go into the cell. Suppose another picture I will draw. So sodium is here. and glucose is also here. There is a pump, we call it as sodium glucose transporter or called as
SGLT.
symporter. Yes,
The
SGLT.
yeah.
SGLT, sodium glucose transporter. Number 1, 2, 3 are many are there, but simply remember sodium glucose transporter. That means this function will only occur when both sodium and glucose will bind. Then only this will be transferred to inside. Okay. Why it will transfer? Because of again sodium potassium pump which is functioning here. So energy is utilized at the brush border, sorry, at the basolateral border, whereas there is no energy utilization at the surface or in the luminal side. So that's why it is a secondary active transport, and it is also known as both of them are moving in one direction from outside to inside. We call it as symport. Okay, symport. Also, there is third type of sodium absorption can take place where there is a pump. We call it as sodium hydrogen. Again, this will not function unless there is a sodium potassium pump here, okay, at the basolateral membrane. So this is also secondary active transport. But here the difference is that hydrogen is going where? Into the lumen, from the cell to the lumen, whereas sodium is moving from the lumen into the epithelial cells. That's why it is called as antiport, antiport transport or counter transport, both one and the same thing, counter transport. This is how sodium is absorbed directly by sodium channels or by sodium glucose channel or by sodium hydrogen counter transport mechanism. Okay,
Clear,
got it?
doctor. Yes.
Yes. Whenever salt, sodium is a like a electrolyte. Along with the sodium, because it is moving plus ions, along with it, chloride will also shift. Why? Because this is positive charges and these are negative charges. So they will be attracting and they will also enter. Once sodium chloride enter, this is a salt. Because of the salt, there will be movement of water. There will be movement of water. So water will also be get absorbed along with sodium and chloride. Osmosis will occur. Okay, as you were seeing that there is a channel we call it as, or protein we call it as SGLT, sodium glucose transporter, which will cause movement of glucose into the cell. Okay. Now it is not only the glucose. There can be glucose, there can be galactose, or there can be fructose also. So how all of them can be transported by only SGLT? No, there are specific channel for each of the different items. Okay. So instead of going to this slide, I will go to the picture. Okay. So see this picture. This is the lumen. On this yellow side is the lumen where whatever we eat, it's reaching here in the lumen. Okay. Let's say there is a glucose reached here or galactose is reached here. So glucose and galactose can be uh, moved into the epithelial cells by SGLT, by sodium glucose transporter. But this sodium glucose transporter is different. Which one? It is called as, the number is different. Let me show you. Yeah, this is SGLT. This is called as SGLT. Once they are inside, like sodium is enter into the cell now, and glucose is also enter into the cell. This is sodium. This is glucose and galactose. Where they will go? They will go to the interstitial fluid here in this space. How it will leave the cell? By the back door, by a special channel. We call it as GLUT. GLUT, glucose transporter, simple, nothing, no combination with sodium. So it is known as GLUT, but this GLUT is having number. So number 2, GLUT2 will transport only galactose, glucose, galactose or fructose, all of three. Whereas if fructose is present in the our diet or in the lumen intestine, then it will not follow SGLT. It will follow another channel. We call it as glucose transporter number 5. So GLUT5 will allow fructose to absorb into the cell. From the cell into the interstitium, it will be the same common transporter GLUT2. And after that, once glucose, galactose, fructose are in the interstitium, it will uh, join the blood or reach into the capillary by simply because of the movement, the what you call the higher concentration to lower concentration. Higher concentration in the interstitium, lower in the blood, so it will move into the cell. Okay, this is the absorption of monosaccharides. Okay, now you may be wondering why we have to remember all these numbers and names. You may be thinking, why GLT or GLUT2 or GLUT1? Why GLUT5?
Deficiencies.
Because there are some drugs which will be taught to you in pharmacology. They are blocking or activating these channels. Okay. Specific drugs are there which are either blocking or activating these channels. So you must remember by which channel, which drug, which element will be transported. Okay. Now coming to the protein absorption. How proteins will be absorbed? Proteins will be absorbed in the form of small unit that is called as amino acids. When protein will be completely digested, it will become a specific amino acid. So there is a same like glucose and galactose, there is a sodium amino acid symporter. Symporter means both of them will move in same direction from outside to inside. Let's say this is the lumen. So sodium plus amino acid, or both of them will move in the same direction by this symporter. Okay. But there is another one more twist is there. Amino acid importers are selective for different types of amino acids. So special amino acid will have a special importer, whereas small peptides are absorbed with tertiary active transport. Now you may be thinking, doctor is confusing us. First he says primary, then he says secondary, now he is saying tertiary. Are you aware about tertiary active transport?
I think so. It acts because of two active transporters, maybe.
All the things. One is the culprit. Who is the culprit?
Sodium, potassium. Bomb.
Correct. Sodium, potassium, ATPase pump. Sodium, potassium,
And then we
ATPase.
have the sodium. What was it? Not the sodium potassium. There was
Good,
also, I think, potassium hydrogen bomb.
good.
Yeah,
Yes, you still remember, huh?
a little
See here,
bit.
yeah, yeah. See here. From the this is the lumen, this side, yellow side. So sodium will move in along with amino acid. This is simple. This is symport. Both of them are moving inside with a symport transport. This is secondary active transport because sodium is moving, because there is on the basolateral side there is sodium potassium pump is functioning, which is making the sodium less into the cell. That's why sodium can move into the cell. Okay, this is secondary active transport. But what is tertiary active transport? Tertiary active transport is that when sodium moves in, there is another pump, we call it as sodium hydrogen antiport, which will throw hydrogen outside. The one which is hydrogen outside will bind to another pump, which is called as hydrogen small peptide transporter. So hydrogen will move inside along with peptide. You may be saying why this is happening. This is happening because this pump will not function unless there is hydrogen plus small peptide together. When they both of them will bind here, then only it will open and it will bring both hydrogen as well as a small peptide inside. Now, where is the tertiary? You will say, where is the term tertiary came? Tertiary came because primary here, sodium potassium pump, because of this, sorry, because of the, what happened? Because of the Primary active transport, there is less sodium inside. So sodium is becoming less. Because sodium is becoming less, there is another pump which is sodium hydrogen antiport, which will bring more sodium here and throw more hydrogen out. When more hydrogen is out, it will combine with this third pump that is called as the hydrogen small peptide pump, and this will transfer hydrogen as well as small peptides inside. By this way, this is the third step. So that's why it is called as a tertiary active transport. Active because energy is utilized at the primary level. Then once it comes here, it will leave the cell through what? Exit the cell by basal membrane via various passive carrier proteins are there on the basolateral membrane, which will throw the amino acid out, and then amino acid will enter into the capillaries. This is how the proteins will be absorbed. Okay, coming to the fat digestion, how the fat digestion will occur. Fat digestion or fat absorption, sorry, fat absorption occurs because of the when monoglyceride and free fatty acids are the product of digestion. They will be forming in the form of, along with the bile salts, in the form of micelles. Where is my cursor? Here. Micelles are water soluble particles will be formed, which is carrying the monoglyceride and free fatty acid to the interior. Then when the micelles will approach the absorptive epithelial surface, as they are fat soluble, they will be easily enter into the cell because of the lipid bilayer is, it will have no restriction for the lipids. Okay, directly enter into the cell.
It will be reabsorbed in the terminal part of the intestine or
Yes, bile
something like
salts will be, yes, bile salts will be absorbed again in the terminal part of the small intestine.
that.
So once I will show you the picture, then it will be easy. All these are the theory, but picture will be more easy to explain. Now in the small intestine, you have got monoglyceride and free fatty acid. They both will combine to make it absorbable. These are micellar formation. These small particles, monoglyceride along with free fatty acids, along with the bile salts, they will become the micellar or small particles. These small particles can easily go into the lipid soluble membrane. Once they enter into the cell, again they will separate or they will combine monoglyceride plus fatty acid to form triglyceride. Triglyceride now combine with, coated with the lipoprotein, which is becoming now chylomicron. And this chylomicron will be extruded out into the space by the process called as exocytosis. So we have seen primary active transport, secondary active transport, facilitated diffusion, and also exocytosis. All these things which we have discussed in the foundation block, now we are repeating here. Once it is there, it will go to which place? Not capillaries. It will go to the lacteal lymphatics. So chylomicrons will be absorbed in the lymphatics, and these lymphatics will drain into where? All the small lymphatics will form. Hmm, any idea where the lymphatic will drain? All small lymphatics will come to form a big lymphatic vessel, and then this will drain into what? No anatomy?
I forgot, doctor.
Do you remember this term? Thoracic duct.
Yes.
Where
Ah,
it will
okay.
go?
Axillary and thoracic. Yeah, yeah, yeah. I remember.
Where
I
it will
think.
go? Thoracic duct.
I don't remember. I take my word.
In the subclavian vein, and then it will be on the venous side. It will be thrown. Okay.
Right.
Venous side. It will drain into the venous side. Thoracic duct will open into the venous side. Okay. This is not our topic. This is anatomy. Either you forget or you remember. Don't know. Okay. Iron absorption. Iron can be absorbed in the form of, there could be heme iron or there could be ferrous iron. Heme iron or ferrous iron, two forms of iron present in the small intestine. They will be absorbed by energy dependent carriers. There are different absorption for heme as well as ferrous iron. Now, one thing is should be clear that dietary iron needed for red blood cell production is transferred into the blood in the form of by the transporter protein called as ferroportin. So iron absorption is controlled by one hormone. We call it as hepcidin. Have you heard about hepcidin? Hepcidin, where you heard? In your previous lecture of liver. Hepcidin is secreted from liver. This is controlling the iron absorption. In the blood, iron is carried in the form of bound to plasma protein, one plasma protein which is known as transferrin, or you can say simply transfer protein. So transferrin is nothing but protein plus iron. So absorbed dietary iron that is not needed is immediately stored in the epithelial cell in the form of ferritin. So ferritin is the stored form. Okay. Unused
Yes,
iron
doc.
lost in the, yeah, unused
Yeah,
iron will be lost in the feces along with the epithelial cells, because we say that every third day or after every 3 days, the epithelial cells or the surface will be becoming new, changed. So anything which is there stored in the form of, like, let's say iron is there, it will also be gone outside. So dietary iron that is not absorbed also will also be lost in the feces. So iron absorption is based on the iron need. How much iron body needs, it will be based on that. And it is said that once you eat around 1 gram of iron, it will be 1 milligram will be absorbed only. So here the picture of absorption of iron, how it occurs. So dietary iron may be present in absorbed and unabsorbed form. Heme iron or ferrous iron, they will be with heme carrier protein or divalent matter transport. Different transporter protein will make them inside the cell. Okay. Once inside the cell, if it is stored, it will be converted into ferritin. If it is has to be transported to the blood, it will leave the epithelial cell through a channel. We call it as ferroportin port, which is a channel. So through this channel, it will go into the interstitial and then join to the blood. In the blood, again, it will be combined with plasma protein to become transferrin, bound to transferrin, and then it will be transported to the site of hemopoiesis. Okay. And this area, that is the ferroportin, is controlled by hepcidin. Okay. So hepcidin role will come to control the ferroportin channel. What is the exact
doctor,
action?
what is
Yes,
controlled by hepcidin?
ferroportin, the one which is the channel
Ah,
which is
okay.
on the
The third one?
basolateral membrane. Here, third one.
Okay.
You have to read what is the exact role of hepcidin from emboss or from somewhere,
Okay.
because it is required.
All right.
Hepcidin, how hepcidin will be controlling the iron absorption. This is, I will give you a hint. It is a inhibiting. It is a inhibitor of iron absorption. Okay, about calcium and vitamins. Very important uh, calcium for body as well as vitamin absorption. And again, it is not indiscriminately absorbed. It is absorbed under the influence of vitamin D. Effect is through vitamin D, calcium absorption. So calcium enter into the luminal membrane, small intestine epithelial cells, along with the electrochemical gradient. Because of the positivity outside, negativity inside, it will be pushed into the cell. Calcium exit the basolateral membrane by a specific channel which is called as calcium ATPase channel. Same like sodium potassium ATPase channel, there is a calcium ATPase pump. Okay. Vitamin D will be enhancing the absorption of calcium. So if you take calcium alone, the absorption will not be maximum. But if you take vitamin D along with calcium, the absorption will be more. Okay. Water soluble other vitamins like water soluble vitamins, they will be passively absorbed with water because they are water soluble. So as water will be absorbed, all the water soluble vitamins will be absorbed. Whereas fat soluble vitamins are absorbed along with the micelles. We have seen micellar formation and they are merging and directly entering into the cell. Again, the important one is the vitamin B12. It is absorbed along with intrinsic factor. So B12 plus intrinsic factor IF, then it will be absorbed. From where intrinsic factor is coming?
Parietal partial or something. Else.
The
Which part of
stomach.
the GI? From stomach. So if the stomach is removed, let's say some part of the stomach was having problem. So if you remove the half of the part of the stomach, then again you will have vitamin B12 deficiency. Why? Because even though you take vitamin B12, the amount of intrinsic factor will be less and vitamin B12 will not be absorbed to its fuller length. So either removal of the stomach can lead to vitamin B12 deficiency, can lead to anemia, okay, or the terminal ileum, the one which is the last part, which is specialized for the absorption. So suppose this part is also removed, you will have vitamin B12 deficiency because it is not absorbed here. So either terminal part removed or removal of the stomach can lead to vitamin B12 deficiency, can lead to anemia. Okay. Okay, once they are absorbed, let's say they come into the capillaries, then where it will drain. And these capillaries, by the way, these are nothing but the part of portal system, portal circulation. And that's why they will take them all to drain into the portal vein, will drain into the liver. This will reach to the liver. And then from the liver, it will go to the superior vena cava and then going to the circulation, systemic circulation. Fat enter the lymphatic, so bypass the liver because you know I told you through the lacteals fat will be absorbed and it will go directly to the thoracic duct. From thoracic duct it will go to the venous circulation. It will drain into the venous circulation, so it will not come into the liver. Harmful substances that have been absorbed because just during the absorption they will be detoxified in the liver. So this is the function of liver, that after absorption everything is reaching to the liver. Okay, coming to the quantity of water absorption, volumes are absorbed. From which source, how much volume is coming? And now you may be asking, so many values are there. No need to remember the values, but remember the concept. Total amount of fluid present in the small intestine is 9 liters and 500 ml, or you can say 9.5 liter, okay, which is coming from food, drink, saliva, gastric juice, pancreatic juice, bile, and succus intricus or intestinal juice. All of them will make around 9.5 liters. Volume absorbed by the intestine is about 9 liters. This is absorbed. So how much will go to the large intestine? 9.5 minus 9, only 0.5 liter. Only 0.5 liters of liquid or water will reach to the large intestine. Out of that, large intestine will absorb how much? Around
Point
3, yeah,
35.
0.35. Yes, 0.35. So how much will be coming out into the feces is only 0.15, or you can say 150 ml. So as I told you, no need to remember all these numbers. Remember the concept. The concept is that whatever may be the amount of liquid or water present in the small intestine, out of that, almost 90% will be absorbed, or you can say a full absorption, except half liter will be remaining. Half liter will be going to the large intestine. Out of large intestine, you will absorb, or the large intestine will absorb around 350 ml. So only a little amount, 150 ml will be lost into the feces. Now, why we should know everything this? Why? What is the logic behind knowing that large amount of water is absorbed? What do you understand? What can be the guess? Why I am telling you in detail about the absorption of water in the small intestine?
Maybe if there is a deficiency or a problem, more water will be unabsorbed. Maybe.
Great. Have you heard about loose motion?
No.
Dysentery, diarrhea.
Yes.
So these are the common term, yani common English layman language. Dysentery, diarrhea, they call it loose motions. This dysentery or diarrhea is because of anything, maybe some unhealthy food, or rotten food, or some chemical, or some drugs. Because of that, or infection, this will lead to dysentery or diarrhea. What is happening in diarrhea? The loss of water will be becoming more. Instead of 150 ml or 150 gram of water, much more amount of water will be lost. What you will do in that case? You have to replace it with water. Okay. So diarrhea is a condition which is causing excessive, highly fluid fecal matter. There is a feces, but it is having lot of water in it. Either increased amount is lost or increased frequency of loss, maybe 10, 20 times per day, or maybe having a very huge amount of in one feces also, one time also. Diarrhea can be beneficial sometimes. Why? Is it beneficial to have diarrhea? Why diarrhea occurs?
To get out
Increase water
toxin.
content.
No, increased water content is called as diarrhea, but it can occur because of some bacteria, some bad food which is present here. So if you want to remove this bad food, not allowing them to be absorbed, the body has got a mechanism to remove it in the form of diarrhea, excessive fluid loss. So in some cases, it is losing, or you can say losing the harmful materials from the body. This is why it can be beneficial sometimes, but it may be abnormal if it is too much loss from the body, can lead to death also. Even loss of excessive water or a severe diarrhea can lead to death, and mainly in children or old person. Children or old person. If there is a diarrhea, this can lead to death. So causes are excessive motility resulting from local irritation. Inside there is irritation in the mucosa, which will cause either by bacterial or viral or any type of parasitic infection, can lead to diarrhea, or can be because of the presence of osmotically active particle. Anything which is attracting water present in the small intestine can lead to diarrhea, such as lactase. We have seen lactase deficiency. So lactose is not digested. So undigested lactose will be present in the lumen, which is attracting water, and that's why water will be lost. So another cause is, more commonest one is the cholera, infection by toxins released by the Vibrio cholerae microorganism. So if these toxins are released, it will lead to loss of water or loss of excessive fecal matter. This is called as diarrhea. Coming to one disease called as celiac disease or known as gluten enteropathy. What is gluten? Have you heard about gluten?
Yes, I think it's a substance,
Yes.
maybe
Where you heard?
in food.
In food.
Is
Which
it
type
found
of
in
food?
bread?
Yes, bread, biscuits,
It's a
cake.
type of
They
protein.
yeah, they label it. This is gluten free. Or maybe if you travel somewhere, they will ask you, are you allergic to gluten? They will provide you in the maybe in the flight, they will provide gluten free diet or gluten free uh, the meal, right? So this is nothing but the a protein where the person is allergic, having hypersensitivity to gluten. This is called as gluten enteropathy, and a condition in which small intestine is becoming sensitive to this protein gluten, which is present in wheat, barley, or rye. These are the most commonest food, and because of that wheat, it is in the bread or in croissant or in biscuits everywhere. So you have to be aware that some people are having gluten sensitivity. The condition is known as celiac disease. Condition known as celiac disease, where the person is allergic or hypersensitive to a specific protein, which is called as gluten. That makes this will lead to some immunological disorder, the reaction. There will be inflammation, there will be more inflammatory cell will go there, like activating the T cells and damaging the intestinal villi. If the intestinal villi is damaged, the one which was initially seen like this, it will become like this. So what is happening here? These villi are lost. What will happen?
It can't be digested.
No, there is decreased surface area.
Uh, is okay.
Decreased surface area. And if the surface area is decreased, what will happen?
Less absorption?
Decrease absorption. Yes, decrease absorption of many things like water, like protein, like everything. Okay. All the nutrients will be all nutrients will be impaired, absorption of all the nutrients, because the surface area which is required for absorption is less. That's why a person will have loss of protein or protein loss, or the body mass will be changed. Okay. This is called as celiac disease. Thank you very much. With this, we come to an end of the lecture number 8, part 2 of small intestine. Any questions?
Thank you, doctor, so much.
Welcome. So let me take the attendance before you leave. I can download the attendance directly here. People, then attendance. Where is the attendance here? Download. Will be downloaded. So very few, only 1/4 are present. Huh? I will send you the recording, inshallah. Let me stop the
Thank you so
recording.
much, doctor.
Thank you, doctor.
I will stop the recording and the link will be shared for the recording, inshallah. Thank you very much.